All right. Hello, everyone. Welcome back to the Improving Flow vertical of this program. So my name's Phil Walmsley. I head up data science at Department of Health and Social Care. Delighted to be here chairing this session on improving flow. And thanks again to the strategy unit for everything they've done and all the other people who've been involved with organising this. It's going very well, I think, so far. Let's bring in our speakers. We've got a talk from some of my good friends and colleagues at NHS England. So we welcome Liliana, Scarlett and Ilias, who are going to talk to us about site-level COVID-19 vaccine demand forecasting, efficiency across NHS vaccination sites. Take it away, everyone.
Okay, amazing. Thank you, Phil, for the introduction. And I'm really happy to present you this project and how at NHS England we use data science and machine learning to improve the distribution of COVID vaccine. So before diving into the juice and how we use machine learning and data science, I just would like to explain briefly how the supply chain of COVID vaccine works, because it's quite different from other vaccines. So basically, the state of England through HACA buys a vaccine, and NHS England is responsible for the deployment, meaning that NHS England is responsible to ensure that across 1,000 of sites, we have the right vaccine at the right time, at the right quantity. And it's quite a complex quite a complex work due to the number of sites and the product characteristic, because, for example, COVID vaccine has a pretty short share of life. So initially, at the beginning of the COVID vaccine pandemic, we had a very restricted number of sites, around 1,000 sites, and each order was raised manually. Now we have increased the number of sites to 7,000, and therefore we needed to find a way to automate the ordering process. And it's why TDM has been developed. So what is TDM? So TDM stands for Target Deployment Model, and it's basically a supply chain model which automatically generates an order of vaccines on behalf of the sites, meaning they don't have to manually. Yeah.
Sorry to interrupt you, but I don't think the slides are moving.
Indeed, the slides are not moving. Okay, interesting. Because they're definitely moving on my screen. Is it better now?
Yes, yeah, that's brilliant.
Yeah, that's perfect.
Oh, okay. All right.
Okay.
I'm very sorry about this. And so very briefly around the COVID vaccine, like HACA buys a vaccine, and NHS England is responsible for the deployment. And because we have increased significantly the number of sites, from 1,000 to 7,000 today, NHS England needed to find a way to automate the ordering process, and it's why the target deployment model has been developed, which is TDM. And basically, what it does, it generates automatically the order on behalf of the site. How it does it is basically use two inputs. Once we have the inventory, on one hand, we have the inventory position. On the other hand, we have the forecast that we have generated. Using both of those inputs, we can calculate a coverage days, which means basically how many days of inventory the site has. And depending on the threshold, an order will be automatically generated for the site. The benefits, it means that it has dramatically reduced the ordering cycle because the order doesn't need to be manually created or approved, which allows basically the network to increase from 1,500 sites to 7,000 today. As I said, we have two hands. One is the inventory, one is the forecast. At some point last year, we thought that we've reached the ceiling of our ability to improve this forecast, and therefore we have reached to the data science team to see how we can improve the forecast and improve this model.
And hello, I'm Liliana from the Data Science and Apply AI team at NHS England, where, as you can see here on this slide, we cover a broad portfolio of data science work, which of course includes the forecasting, which brings us to today's presentation. We can go to the next slide, please. So the question we needed to answer for Ilias's team seems straightforward enough. What does vaccine demand look like at each site delivering a COVID vaccine over the next 14 days. What makes this forecast peculiar is that we're doing it for more than the 6,000 sites, and its timeline isn't precisely a regular one or consistent one. We'll see on the next slide, thank you, that in a year there are 2 vaccination campaigns with a break in between. We open on a high level of demand, going down quickly to a minimum level. And naturally, we can observe some seasonality. However, this behavior isn't always mirrored at the individual sites. There are massive variations. While some deliver less than a handful vaccinations per day, others are in the hundreds. Some have high levels of vaccines, while others are booked in advance only. So how do we do it? To build a forecast, we're using past number of vaccinations and how many people have booked and the implied walking rate. The capacity each site has, we call it the slot capacity. We have the bookings to date for each of the next 14 days, but obviously that can change as we get closer. And we also have some temporal factors like day of the week and any bank holidays, days until the campaign ends. We encode it all, plug it into the model. After testing several algorithms, we chose LightGBM. It's a gradient boosting decision tree because it provided the best performance and was also very quick to train. It's not a native time series model, so we had to translate the time into features so it doesn't see dates. It gets lags and rolling windows. So we train as a global model, so that's one across all the different sites, but it's capable to learn the patterns from the data-rich sites, and it transfers even to new sites for which we don't have history, just by the characteristics. So to handle the complexity on a 4-day forecasting horizon, and then therefore 14 distinct models, we use DARTS. It's a library for time series that automates the feature derivation and the wrangling. If we go to the next one, please. We validated the model on a spring in the 2021 campaign, and most importantly, would compare our modeling with the TDM, the current deterministic approach that Ilias mentioned, used to place orders which appear on the plot as the blue line. The black line over there shows the improved accuracy of about 20% that LightGBM brought. With this approach, we built a pipeline to do daily retraining and do the forecast ready for the next campaign, the autumn-winter 2025, which started on the 1st of September, and Scarlett will tell you what happened then.
Brilliant, thank you. Okay, so what we did after we got these results is we did a live model deployment. So we still had the deterministic part of TDM running as well as the LightGBM forecast. And kind of to take the best from both, we decided to sort of take the best value from both while also monitoring both at the same time. Next slide. What we actually ended up finding, so just going to very simply explain bias, which is the metric you're seeing here. When bias is above 0, on average, we're over forecasting for that particular date. And when it's below 0, that means we're under forecasting. So as you can see for the spring campaign for our model, when we were looking at it, so this is the black line, we saw that it was tending towards a 0. But unfortunately, what we did see for the autumn winter campaign for this current deployment, we actually saw it was over forecasting. And go on to the next slide. So there's a couple of things that we wanted to explore to try and explain this. Something that we think did contribute to this is actually the eligibility criteria for getting a COVID vaccination had changed. It went from going to over 65 to over 75. And what ended up happening is we had an extremely higher cancellation rate, specifically at the beginning, more so than previous campaigns. And booking signal was actually one of our most important features. So we think this contributed to it. And another thing as well is because of the eligibility train, we had a smaller eligible population and we had more active sites, which meant that vaccination events across this winter period was also a lot smaller than it has been on previous years as well. Next slide. So other things that we decided to look at was some general improvements to the model. So I had noticed that actually we have a lot of zero vaccine events. So for example, if you think of it per site, they might be closed. So therefore there's going to be no vaccination events on that day. In the literature, it's shown that actually a regressor can sometimes struggle with this because it will still predict small numbers, even though there actually should be no activity on this date. So it actually suggested doing a classification and regression kind of model setup and then combine it. So we decided to investigate this. And then the other thing was actually looking at an objective. So when you're training a LightGBM model, you're trying to minimize loss. And the default for this is something called mean squared error. So you're squaring the error. Unfortunately, this is actually quite susceptible to outliers. So we decided to have a look at mean absolute error to see how this could improve the forecast. Next slide. What we found was actually the combination of the classification lasso regularization actually significantly improved the results from our old model, but also the TDM model by itself as well. I'm just going to hand over to Ilias to just summarize everything.
Thank you very much, Scarlett. And so to conclude, the business value of this project was clear, in particular after the change of objective to lasso regression, and we saw a 20% improvement of the forecast accuracy, and it's why we decided to push this model into production for the current campaign, which has contributed to reduce waste and save admin time. One of the lessons learned, it might be obvious, but always monitor a model and consider dual deployment. In particular, if the environment where the model is about to be deployed is changing or has changed compared to the previous campaign in that case, as Karen mentioned about the change of eligibility and the increase of the number of sites. But thanks to this success, we're looking to extend the development of this model to GPs for the next campaign in spring, summer, because currently it's mainly used with pharmacy. And in general, I think there will be, and there are many opportunities to use data science into our operations. Thank you very much.
All right, thanks everyone. That was super interesting. So let's have a quick look over at the Q&A. So people got a moment just to get a couple more questions in, but I'm interested in, because you explained how we have some extrinsic thing, which is, the change in the eligibility criteria has thrown the model off. This is a very general problem. Maybe you can talk a little bit about how we should be handling that kind of issue when we're dealing with our models. No, sorry, there's three of you, isn't there? I need to ask someone. Go on, Scarlett, you can take that one first and then maybe hand on.
Yeah, I think, well, there's a couple of things there, isn't there? Because I think one thing that we now want to be looking at is actually monitoring data throughout the whole life cycle. And that's more just to flag where those kind of situations are happening. And obviously that's easier said than done when you've had the experience and you know that that's going to exist. Like, it's kind of hard to see the unforeseen. The other thing I've thought about as well is possibly adding those data quality metrics into the model itself and seeing if that can improve it. And I guess we kind of have the example now of this data to test that, but that's something that we haven't done just yet. Like, to clarify, all of this has very much happened. I mean, some of this has been the last week or two, so it's very, very up to date and very new. But yeah, there's two things there.
Yeah, no, but an interesting point about, in theory, you can go and model your data pipelines for anomalies, and then when you see sudden changes or whatever, or something outside of an SPC band or whatever it is, that might at least get you there. I was going to ask as well, your point about reduced waste. Is there any record for waste? Because something that's always in my mind as sort of someone a bit more in the management of all this is, how do we demonstrate actually the pounds and pence impact of when we put a model like this? Linking back to the keynotes earlier, which were saying, we've got to get off the fence and show that we're making, really valuable differences. So have you got any idea in terms of that sort of really quantitative evaluation of waste reduction here?
So the waste, thank you very much for this question, Phil. So the waste come from different sources, right? We have the pack size itself, because basically unlike flu vaccine is not a single doses vaccine, so we have a pack size of 60, which is a part of our operational waste, and so in general it's kind of difficult to measure, but definitely the improvement of forecast accuracy helps contribute to reduction of waste, but it's difficult to measure and to give you one number and to link directly like the improvement of the forecast to the wastage.
Thanks very much. So we are out of time. I know that Sarah's got a question about supply chain cases. I'll leave everyone to mull over in the Q&A end there. But thanks very much to our speakers, and I believe we have Rania waiting to come on next.